Good morning, everyone. Today we will start with a new topic which is known as joint mobilization. Joint mobilization, these are techniques which comes under a specialization which is known as manual therapy. These techniques are given by the therapist manually. These are skilled techniques which helps in reducing pain, improving joint play, correcting dysfunctions, correcting aberrant motions. So these techniques will help us in treating various disorders, musculoskeletal conditions in a patient. Now what is joint mobilization? As we just spoke previously, these are the techniques which comes under manual therapy specialty. These help in reducing the pain. It helps in increasing range of motion. It helps in treating joint dysfunctions that limit range of motion by correcting the altered joint mechanics. Now, what is joint mechanics? You know, normal biomechanics, normal functioning of a joint. Now, when there is some dysfunction in the structure, when there is some issues in the structure, the normal biomechanics is altered, it is changed. So patients will have uh, altered movement, they may have altered range of motion, because of which there will be limited range of motion, there will be increase in pain. So if the normal joint mechanics is altered, various issues come in. So these techniques helps in correcting all of these issues. Now, coming to factors that may alter joint mechanics. Now, what will alter your normal biomechanics? The normal biomechanics of a joint can be altered when there is pain, when there is muscle guarding. Muscle guarding means whenever you have pain in a particular joint, the muscles surrounding those joints will become spasmodic, will become tight. Why? Because those muscles are guarding the joint, protecting the joint. That is known as protective spasm or muscle guarding. So if whenever there is a pain in the joint, muscle will come into picture and it will start protecting the joint so that the patient feels lesser pain. And once the muscles start guarding and when there is spasm, definitely the movement won't be complete. The range of motion will reduce. There will be altered joint mechanics. Okay, that was the first point. Now, second is joint hypomobility. So, hypomobility term we have already discussed in modules of goniometry, wherein there is reduced movement in the joint. There can be any factors which would have caused reduced range of motion of a joint. Okay, joint effusion is one of the cause which may reduce joint range of motion, which will be one of the cause of hypomobility. Joint effusion is nothing else but swelling. Why there will be a swelling? There could have been an injury, a trauma, which would have led to inflammation and swelling. The next is contractures or adhesions in the joint capsule or supporting ligaments. These contractures and adhesions are permanent or temporary tightness of the surrounding structure of a joint. Those surrounding structures of a joint can be capsule, they can be ligament, and other soft tissues can also become tight and adhered to the joint, which causes reduced range of motion. If the structure surrounding joint becomes tight, just like the muscle guarding, if the structures like ligament and capsule surrounding the joint becomes tight, definitely the range of motion reduces, and if there is reduced range of motion, there will be altered joint mechanics. Now the last is malalignment or subluxation of bony surfaces. When there is uh, slightly malalignment or aberrant joint position, or there is a dysfunctional joint position of the bony surfaces, that can also lead to reduced range of motion and altered joint mechanics. So now in this slide, you must be thinking that the factors which alters joint mechanics is one of the factors hypomobility. So whether we should mobilize somebody with hypermobile joint, whether we should do that or not. So you can see these images where these people are highly flexible. We can say they are hypermobile. They may have hypermobile joint. They may have lax ligaments. So whether we should be thinking to mobilize such people. So the thing is, now we learned that mobilization helps in reducing pain. It helps in improving range of motion. So when there's already increased range of motion, there's hypermobility, we should actually not mobilize such joints. We should not think of increasing the range of motion. We should not give mobilization thinking to increase the range of motion. So hypermobile joints, we are not supposed to do further mobilization so that we should not increase range of motion further. So certain terminologies you'll come across when you are talking about manual therapy and mobilization. So the first the terminology is mobilization itself. So the definition says it's passive joint movement which helps in increasing range of motion or decreasing pain. So mobilization technique which we are going to talk in this module is a passive technique. That means the therapist is going to apply the techniques on patients and patients are not going to assist at all. So these techniques are applied to joints and related soft tissues at different speeds and amplitudes using physiologic or accessory motions. So in the previous module of goniometry, we have learnt about what are physiologic and accessory motions. Physiologic motions were those voluntary movements which a patient does and which you can observe. For instance, flexion, extension, internal rotation, external rotation, abduction and adduction. These are those gross movements, large movements which you can visualize, and these are voluntary done by the patients. Accessory motions, we have learned this also in the previous classes. These are those movements which are happening within the joint surfaces. These are the joint play or the movements like slide, rolling, spinning. These movements which are not under control of a patient or a therapist and done involuntary is known as accessory motions. Now next is the amount of force which is applied during mobilization by the therapist is light. It's not very high, it's not very strong. Those are light forces which is applied by the therapist on patient, and patient will be able to stop the movement if he's uncomfortable. He can tell you that you can stop now, I'm getting pain or I'm uncomfortable. It is in control of patient. So these mobilization technique will be in control of patient. Now coming to manipulation, these are the passive joint movement for increasing joint mobility. So this is also passive, but what is the difference between mobilization and manipulation is manipulation incorporates a sudden forceful thrust that is beyond the patient's control. Okay, so it's given only once and it's a forceful thrust technique wherein the patient will not be able to stop the therapist if he or she gets pain or if they are uncomfortable. So that is a basic difference between mobilization and manipulation. Now coming to different terminologies of mobilization, there is something known as self-mobilization or auto-mobilization. Now, when the term comes as self or auto, which means that therapist is not getting involved in these techniques. These techniques are actually done by the patient by himself. The therapist will teach these techniques as a self-management program or a self-management technique or a home program technique. So these techniques can be given to patients so that they can do it by themselves in home if they are unable to come. So these are the self-stretching techniques that specifically use joint traction or glides that direct the stretch force to the joint capsule. Now coming to another technique of mobilization, which is known as mobilization with movement or MWM. So these are the techniques where therapist is giving a mobilization technique and simultaneously the patient does an active movement. So it is a concurrent application of a sustained accessory mobilization applied by a clinician and an active physiologic movement to end range applied by the patient. So both therapist and the patient are simultaneously doing the technique. Okay.
So now coming to terminologies. These terminologies we have discussed in the previous modules of goniometry. The first one is physiological movements, which means those movements which are done voluntarily. These are the gross movements which you can see while performing. These are the movements are like flexion, extension, rotations, abduction and adduction. Osteokinematics also we have discussed in the previous modules of goniometry, which is nothing else but the motions or the movement of the bones. Accessory movements are those tiny subtle movements which are happening within the joint surface, inside the joint surface, which is also very important and necessary for the normal range of motion. But they cannot be performed voluntarily. These movements are spinning, rolling, sliding, gliding, distraction and compression. So these accessory movements are very important to complete a range of motion. If accessory movements like the sliding or the gliding or the rolling is affected, the range of motion will reduce. So it is very important for the accessory movements to be very smooth. Another terms are joint play. Joint play term is used when we talk about these accessory movements. We talk about sliding, gliding. These are the motions again happening within the joint. So accessory movements or joint play, we can use it as interchangeably. These are the similar terms which mean same. So this joint play can be determined by joint capsule's laxity and it can be demonstrated passively and not performed actively. So under arthrokinematics, we have 5 movements, which is rolling, sliding, spinning, compression, and distraction. Coming to another manual therapy technique, which is known as muscle energy technique. This technique, uh, in this, there is active contraction of muscles performed by the patient against the resistance given by the therapist. This technique is different from mobilization, which is acted directly on the joint. In muscle energy technique, there is active contraction of the muscles and the movement is done against the resistance given by the therapist. Then we have thrust technique, which we learned in the previous slides. Thrust is nothing else but manipulation technique. It is high velocity, short amplitude motion, which the patient cannot prevent. This movement or this technique, when therapist is giving, the patient cannot control the technique. It is performed at end range of pathologic limit of the joint. This technique helps in breaking the adhesions and stimulates the joint receptors. Now coming to another terminologies, these are the basic terms, concave and convex. Concave means a surface which is hollowed or rounded inwards. A convex surface is curved or rounded outwards.
So as discussed in the previous slide, the joint can be of concave or convex shape. There are other joint shapes such as ovoid and cellular. Now what is ovoid? Ovoid is a shape where one surface is convex and the other surface is concave surface. Cellar, in cellar surface, one surface is concave in one direction and convex in other direction, with the opposing surface convex and concave respectively. So we have these four types of joint shapes. Now, if you remember in arthrokinematics or accessory movements, we have discussed that there are certain movements like rolling, spinning, gliding, distraction. These movements are known as accessory movements. So these are again basic terminologies. Let us discuss what is rolling now. So in rolling, a series of points on one articulating surface comes into contact with a series of points on another surface. So if you see that figure, now if you roll a ball, just visualize while rolling a ball that one point will come in articulating, or it will come in contact with a series of points on another surface. If you're rolling a ball, the uh, points on the floor will keep on changing, and points coming in contact of the ball to the floor will also keep on changing. There are different points on ball and surface which is come in contact while the ball is rolling. So that is why a series of points on one articulating surface, for example, a ball if we are talking about, just to make us understand, which comes into contact with a series of points on another surface like your floor. So example is ball rolling on the ground. Now similar example, if you talk in your joints, femoral condyles rolls on the tibial plateau. So what we are trying to say is there are different points on femoral condyle will come in contact while rolling on tibial plateau, different points on tibial plateau. So whenever the surfaces come in contact to each other, different points are coming in contact. Now this is a very important point, that is why I have highlighted in the red. Rolling occurs in the direction of movement. If you are talking about, for example, humerus, when you're doing abduction, in which direction the bone is moving? The moving bone is actually humerus. While you're doing abduction, the bone is going superiorly. The rolling will happen in the same direction of the movement of the bone. That means when you're doing abduction, the humerus is going superiorly, which means the rolling is also happening in the superior direction. So this is very important. You need to remember rolling happens in the same direction as of the moving bone. So when you're doing adduction or you're taking the arm down, humerus is coming downwards. So where is the direction of rolling? The direction of rolling is inferior. Okay, so please remember, this is very important to understand convex concave rule, which we'll talk in later classes. Now rolling occurs in incongruent surfaces. Rolling occurs in surfaces which are unequal. Now just imagine femoral condyle. Femoral condyle is a ball-like structure and tibial plateau is a kind of flat structure. So those are unequal surfaces. Both have different shape. So rolling occurs on something which have both the surfaces should be different, like a ball and a ground. So ball is round and your ground is flat. So only then an object or a joint can roll if the surfaces are incongruent. Rolling never happens alone. It happens usually in combination of sliding or spinning. Rolling is not an independent movement which happens within a joint. It always happens with a combination of sliding or spinning. So this was about rolling. Now coming to spinning. So before you understand spinning, you visualize a spin top, which I think you would have uh, played when you were young kids. So spin has an axis. Any spin has an axis. around which it rotates. So, as the definition says, it occurs when one bone rotates around a stationary longitudinal mechanical axis. So, when you're spinning something, the point, the object which is spinning, that axis of that object will remain the same. It will remain the constant. However, it can spin in various other points of the surface, other surface over which it is spinning. So same point on the moving surface creates an arc of a circle as a bone spins. Example is your radial head of the humeroradial joint during pronation or supination. Then in shoulder, you have flexion or extension. And then in hip joint, you have flexion or extension. Now, what are we trying to tell you? That, see, I have given example of shoulder abduction in case of rolling. So, in case of shoulder abduction, while doing abduction, the humerus rolls superiorly. Okay. Now, in case of flexion, shoulder flexion, actually there is no rolling which is happening. There is a spinning which is happening. Okay. So, there is a spin movement which is going on in the shoulder flexion and extension, and similarly in hip flexion and extension. Now, spin does not occur by itself during normal range of motion. Okay. So now we'll talk about sliding. So this is an example. This is a slide which you can see. Specific point on one surface comes into contact with a series of points on another surface. So while you are sliding on a slide, there's a particular point in your body which will be in contact with the slide. Okay. In this, the surfaces are congruent. Now, this we are talking in terms of joints. So sliding will happen when the joint surfaces are congruent, when they have articulated well. Okay. So when a passive mobilization technique is applied to produce a slide in the joint, it is referred as a glide. Combined rolling sliding in a joint. The more congruent the surfaces are, the more sliding there will be. Okay. And the more incongruent surface, the more rolling there will be. So you have to remember that two things. Rolling happens when the surfaces are incongruent, and sliding happens congruent. Now we'll talk about compression and distraction. These are the last accessory movements which happens in our joints. So compression, something which is pushing, something which is approximating the two joint surfaces, something which is decreasing the space between the two joint surfaces, is known as compression. When you push one joint surface to another joint surface, is known as compression. So there will be decrease in space between the two joint surfaces. It enhances stability to a joint. The normal reaction of a joint muscle contraction helps in compression of the joint. So when you are contracting your muscles also, it will help in compression of the joint. So that is compression. Coming to distraction, when two joint surfaces are pulled apart from each other, that is known as distraction. It is often used in combination with joint mobilization to increase stretch of the capsule. So if you are pulling two joint surfaces, definitely you are going to stretch certain structures. So in case of joint distraction, what we give in mobilization, you are actually trying to stretch the capsule of the joint. If we are doing distraction during mobilization, it helps in reducing tightness, breaking adhesions. It improves range of motion when you simultaneously give the mobilization techniques. So these points are important to remember because when you learn mobilization techniques, you need to know in which direction the rolling is happening, in which direction the sliding is happening. What is compression and distraction? What is the effect of compression and distraction? So now compression, when you compress two joint surfaces, it actually helps in improving nutrition to the joint surfaces. Okay, when you are compressing, there will be pushing in and out of the synovial fluid, and synovial fluid helps in exchange of nutrition. So these are very important points which we need to remember. Physiological movements, which you know that the gross large movements which we do, which we see, which are voluntarily, but accessory movements are those important movements which are happening within the joint. Now you cannot treat accessory movements by just doing physiological movements. So for that purpose, mobilization is needed. For that purpose, you need to know how rolling happens within a joint, how sliding happens within a joint, how to do retraction and compression. So because these are the techniques which we are going to learn during practical sessions of mobilization, how to perform sliding, how to do compression and distraction, that will help in improving the accessory movements. So now what I am trying to tell you in the last slide is uh, please understand that mobilization helps in improving range of motion. It helps in reducing pain. It helps in correcting any malalignment or dysfunction within the joint, any aberrant position within the joint, because of which there is reduced range of motion. Now you need to understand it very clearly just by giving physiological exercises or physiological movements to the patients. The range of motion will not become better because your complete range of motion depends upon two movements, which is physiological movements and second is accessory movement. If your accessory movements are reduced, then there will be overall reduced range of motion, and that will only get corrected when you give glidings, when you're giving mobilization techniques which is directed to that particular accessory movement, which is directed to that particular glide. You need to know which particular glide will improve abduction, which particular glide will improve internal and external rotation. So for that, these are the basic terminologies we dealt in the module 1 of mobilization. So in the consequent classes, we will learn about something very important, which is convex concave rule. And you need to know that rule because you need to know how to determine, how to understand which glide will improve certain movement. A single glide will not improve all the movements. For if you want to improve abduction range of motion, you need to give a particular glide. If you want to improve rotations, there are different glides. So to find out which glide is affected, which glide a therapist should give on the patient, you need to remember and learn convex concave rule. And to know convex concave rule, you should know what is rolling, sliding. It is very important. So I hope the module was informative. Definitely it is a new topic. It will take some time to understand. So these are the basic concepts which I had discussed in the PPT. Please refer Carolyn Kistner. It has peripheral joint mobilization chapter, and you will understand better once you read the PDF of the book. And we will discuss about this PPT in the consequent practical hour. So please be ready with all the questions which you would have while going through the module. So I hope the session was clear. Thank you so much.